So we're very happy today to have a presentation by Armin and his team that is going to show research work that's been being done for quite a few years now that really puts practical application, real world stuff on all of the abstract standards and specifications that we've been talking about. So I'd like to welcome Armin to our Friday SDPi session and take it away.
Okay, so I'm going to start, and I have a short presentation, and later we're going to switch to a live demonstration of our surgical workstation with Okan Yilmaz. He's going to present it directly from the lab. So let me have a look if I can start that now. 1 second. Okay, so now let's have a look if I can share the screen. Should start, hopefully. Now, can you see something?
Yes. Well, it's coming.
Okay.
There it is. Got it.
Works. You can see it? Full screen?
Yes.
Perfect. Okay, so I'm going to start. So we are from the Chair of Medical Engineering from Aachen University, and we are working on the open interconnection of medical devices since 2005. And we're going to show you what is our focus. Our main focus is in integration, as you see, the working group title, risk management, usability engineering. We are developing also new interfaces for the OR stuff, and we're going to show you some of them during this presentation. You see, our location of the Helmholtz Institute of our chair is directly next to the University Clinic in Aachen. And our chair is in the Faculty of Mechanical Engineering, although we have in our chair, I guess 1/3 mechanical engineers, electrical engineers, and biomedical engineers, informatics also. And I studied information and communication technology at Aachen University. And since 10 years, I'm now, I can lead this group, this working group, which is really exciting. So, just to see about our location. This is our main working groups. We're in the middle, our group, but our chair is also in medical image processing, biomechanic modeling, also smart instruments and robotics is also a topic right now, what we have to integrate them in our SDC network. And we are talking right now, or since some months or some years already, about connecting SDC with TSN, for example, so that we are having the hard real-time requirements fulfilled. And this is something we are working on also with Martin. I see Martin is also here, Martin Kasparik. So something we're working on in this field. So this is something which is our group working in. You see the risk management process on the top. So everything what you see today is really discussed, the requirements analyzed, and the conception, also the evaluation, has been done with the clinical partners from neurosurgery, from orthopedics, ENT, and I'm going to show you some other fields which we are working on. This is somehow the beginnings. I remember the SmartOR.NET project in 2009. It started on the left down in the presentation. This is something we are doing. I'm going to go over it very fast. We have also usability lab in our chair, and with different kind of tools, video documentation, physiologging, and also an eye tracking system for doing really this analysis with the clinical stuff in our demo OR. This is some clinics we're working on, especially in Aachen. As I mentioned, from ENT, neurosurgery up to cardiovascular technique or systems. So, and but we're also connected with different kind of other clinics. Here, as you can see, I think nearly everybody in this group, in this meeting today, knows the partners from OR.NET, where we came from, a big project in 2012 till 2016. So I would say the who's who of the medical device manufacturers, and they all wanted to know how this SDC approach works. And also one big question for everybody, how we can do the approval process of these systems finally. Some impressions from our trade fairs, former ConHIT, Connecting Healthcare IT, and now DEMEA, where we have been with our project. And as you can see, I think this was in 2016, as you can see down on the page, on the slide. A lot of systems, a lot of use cases, which we try to show. And in a big booth in 2016 it was. And now this is the last one where we could show the public our approach, our results from a part of our workstation, which you can see here in the front in the Ordered.net Association booth in 2019 at the DEMEA. And these here's some familiar faces, I guess. Martin, Fabian, Okan, working on that. And this is the surgical workstation where Okan is going to present later on. OR tables, high frequency cutting devices, endoscopic devices, which we connected on the base of SDC, and which we got from different kind of manufacturers. So we had to implement the SDC interface together with the manufacturers. Some impressions from the Medica, where we also presented our surgical workstation. And this is the devices we had in our demonstrator in 2016, in the end of the Ordered.net project. We don't have all of the devices. For example, the OR microscope, we don't have any more in our chair because it was something we could use during the project. But trying always to extend our device set. So this is the head of neurosurgery in Aachen. This is Professor Klusmann and his team. I'm quite happy to have them on board. Since a lot of years, he is working with us on the use cases with us, and is evaluating and also analyzing the requirements here, an application here for the movement of the OR table, an interactive OR table model, which we developed with them. And quite happy to have them on the team. You see here the OR.net Association, and here the website. I'm going to skip that fast. And I'm going to show you a bit more about what we developed in our chair and what kind of possibilities we have. For example, the OR table control, as I mentioned it here, we have an interactive OR table model. We can press the different kind of devices, the different kind of components, and then we can move them in the direction we want, or the clinical user wants. And we have also for sure different kind of Trendelenburg, anti-Trendelenburg. This is movements which are risk critical, so risk sensitive, and the clinical users always need kind of these movements in the OR. What you can see here is a function group view, as we call it. And this is process specific. So everything the surgeon needs right now in this moment, we are trying to give him to in one view. And so he can, in this case, he could use the OR lights, the high frequency cutting device, the ultrasound device, or also, as you can see on the left down of the slide, our universal foot switch, which I'm going to explain more in detail later. And I'm also going to explain something about the framework. On the left side, you see the different kind of disciplines. There's also the surgical part, and also the anesthetic part, also functions, for example, controlling the room light, or the jalousies, or different kind of other components which the clinicians are used to deal with. On the downside, you can see the different kind of process steps within an operation, and this is connected to, for example, the WHO, the surgical safety checklist, So I think there's another possibility to have an electronic documentation of this safety checklist. And right now, I think in most of the clinics, you have this done by pen and paper. And yeah, this is a universal foot switch, which we developed with Enterprise Steute, which I think have in Germany about 70–80% of the market when it's about medical foot switch. And if you, for example, use a Siemens X-ray C-arm, then normally you're using a Steute foot switch, which is in combination brought into the market with Siemens. And this is something we developed with, especially with the neurosurgery, because they have a lot of devices to control up to 10 foot switches, I would say, right now in operations. And there's always the problem that the foot switch has to be found by the surgeon. And if he doesn't find the foot switch, or if the foot switch slides from a footstep, for example, which also happens a lot of times to adjust the different heights of the OR personnel, then unsterile nurse has to put the surgeon the right foot switch in front of the foot. So this is something we thought we could optimize. So we developed a lot of years ago, and we tried to optimize it, this universal foot switch. And this could be something for the different kind of disciplines, and this one here for the neurosurgery, where we try to optimize the workflow and try to decrease the interruptions in the OR workflow. This is a medical tablet, which we also developed in the last years. So you also have the possibility in our workstation to use the different kind of devices from a tablet, or for example from a smartphone. As you can see it here, the OR lights, which are controlled by a smartphone. This is something in research stadium, but we really think that this could something be, if you think on a medical tablet for the operating room, which, for example, has a confirmation button, for example, a hardware confirmation button. There we can imagine something also for wrist-sensitive devices, like an OR table or X-ray C-arm. But right now, this is only for, I would say, use cases like controlling OR lights or switching video pictures, or something which is not as risk critical as when you release a device, for example, high frequency cutting device or a table. You can understand me, or everything fine, hopefully?
Yep. So perfect.
Then you can
Absolutely.
see here a video switch, which has been developed by my co-worker Okan Yilmaz, and he's going to show you in live later how it works. But you have the possibility. The streaming is not with SDC, but the control of the different kind of displays has been done with SDC. And so this gives the surgeon or the whole OR staff the possibility to put the different kind of data on the displays they really want. This is something new. I didn't show it last time. This is a motorized height adjustable footstep, and this is something we know that the surgical team wants something like this. I think they have a standardized height, 15 centimeters, 30 centimeters, and 45 centimeters. And we know that something like this is also, if it is, for example, interconnected with the OR table, and you move the OR table up or down, if you have to, for example, blood pressure fall or something, then you are also able, if this footstep is connected with SDC, which we already did, you also can go relatively with in a relative direction with the OR table. So this is something really optimizing the workflow. Finally, someone has to bring this into market, but maybe it's a bit too expensive, but I don't know. So maybe it will take some years, but it's something we're working on. And yeah, and this is something I also didn't mention last time. This is a remote pointer which we implemented some years ago in our workstation, and I think we're not going to show it today, so I'm going to present it here. If you use the infrared tracking system and you use a reference pointer in any way to match the intraoperative data with the preoperative pictures which you did. And then you can use this if you open up with a trigger like on a pistol. You open up one of the balls which reflect the infrared light. So this is detected by our system and is interpreted as a mouse click. So you can use it really to move the mouse on the different kind of dialogues on the screen. So this is something we did in 2005 when I remembered. It was the first ideas, and then we implemented it. And in 2017, I saw this kind of system with the new autopilot system from Escolab. So it took quite some time, but then it was in the market, and it was quite optimized version as we had it in our times, I remember. But it's really nice to see something on the market. It's a shame that we didn't have a patent on it, but yeah, this is something I just wanted to show here in the and yeah, another topic is that we are really working on the approval process. And as you can imagine, if you regard the design dossier, what kind of different documentations have to be fulfilled and done, and the requirements which have to be fulfilled with an additional SDC interface. And you, on the one hand, you have the technical part where you do finally the verification, and you also have the validation part where you have the usage of the system. And we are really working on a guidance document right now with the notified bodies in Germany, and hopefully soon also with the notified bodies in Europe. And every 2 months we have a meeting here, and really trying to have how we call it, an acknowledged process which we can give to the manufacturers in order to go on with the approval process of the devices like that. And yeah, we're really happy to establish this working group in Germany with the notified bodies. Yeah, this is until here my presentation, only very short, and because Okan is going to present more in detail in the. Oh, I don't know if I can.
So before you do,
yeah,
one question is, these are great systems and great demonstrators, and a few times you've mentioned parts of this that have gone to product or headed to that direction, but also you've mentioned parts where it uses SDC under the hood, right, for connectivity, but it's not always clear which parts of this are SDC enabled and which parts then actually do the value add and present information or use the controls or that thing. Is there any, maybe that's something that Okan can kind of talk to also during the demo?
Yeah, I think we leave it up to the demo, and then if we see the different kind of devices, then Okan can explain what is SDC related and what is the added part. So I don't know if I can. Here now I understand how to stop the video. Or to stop the screen sharing. So now I think Okan can.
Okay, I hope you can hear me, and I also hope you can see the web browser and the
we see it.
Screen sharing.
Yes,
perfectly. So here we have our workstation. On the left side we have navigation, and in the center we have the medical device panel. So what do we have the workstation for? Here we can see we have a demonstrator, and here we have around 7 to 10 different devices from different manufacturers. For example, endoscopic tower with an endoscope, light source. We have a high frequency cutting device. We have all tables. We have food switches, and so on. Of course, we have 2 OR lights. I hope you can see them. One is above me and one is right there. And what we did, we translated the manufacturer protocol using partly a microcontroller into SDC. So So what we do, if we want to drive the table up, we send the signal to the microcontroller, and the microcontroller translates it to SCC and sends the signal to the table. With that, I'm also able to move the legs of the table in front of me. And since we also have a tablet control for all medical devices, I can do it backwards. And well, we can go through a few devices. So the anesthesia part, Jonas will tell a little bit about it later in detail. So we skip to the surgical part. We have different devices here. For example, an endoscope. On the right side, you can see a split screen of 4 different video inputs. And now you can see the bottom 2 panels show the endoscope. And using a touch screen, I can turn it on and off. The advantage we have here by using the touch screen is, well, on this endoscope, we have 3 very small buttons. And using those 3 buttons, you can navigate through all the settings of the device. But the problem is you need to click like 5 to 10 times to change a certain properties. And using like everything you can see here on the screen, the light source, illumination power, zoom, image processing, image settings, presets, those are all usually selectable by those 3 buttons on the endoscope, but it's not very efficient and it's not very fast. So using a workstation speeds up processes, and you can also have, for example, presets. So in preparation of an operating procedure, or depending on the workflow step, you can just set the presets and start the operating. So there is no need to calibrate each device one by one. You can just click a button and apply the presets. And
just for anybody, Okan, one point. I don't know if everybody sees the 2. One is the camera of Okan, where you can see the demo OR, and one is the screen sharing of our workstation.
We just see the screen sharing. We don't see what Okan is doing.
If you skip to Okan, to the camera, you can see the whole OR, the whole demonstrator OR. Then you can see both.
It's the camera image. I hope you can.
Camera image. So Okan is.
Well, maybe you can set a focus on the camera. Is it possible?
Actually,
and not on the screen sharing.
No. And I think that there is no camera image from Okan.
Yeah.
At least in my view, not.
Not on mine.
If you do right click and remove all the. Oh, wait a second.
All right, I see him now.
Yeah. No,
it's only a small window.
Yeah, I don't know how to adjust it neither. So I would like to see these both pictures big, but
maybe if I stop screen sharing.
No, it's okay. It's okay, Okan. It's okay.
I think there is a right click on Okan, and then there is a move to stage.
Oh yes, perfect.
Now I have it side by side.
Me too. Me too. Thanks, Martin. I think this is much better to understand all the.
Yeah.
And it's much better for the recording. So.
I hope that works for most of you.
Perfect.
Well, I hope in the first part now you can see all the devices here also. And on this picture we have a food switch. For example, this food switch has 3 pedals and a joystick on the right. And I have the food switch I have here on the table, also on the ground. And if I press the pedals, I can change the function. I can use the functionalities of different devices. So using one food switch, I can control multiple different devices. For example, on the center button, I can change the zoom on the endoscope. You can see it on the right screen at the bottom. You can see as the endoscope zooms in. And if I zoom out, it's again very small. And on the left pedal, I have a shaver here in my hand. I don't know if you can hear it if I activate it. And using the food switch, I can change the properties of the pedals. So if I click once, I can just free-handed I can change the preset of the foot switch. And if I had found something, for example, on the yellow pedal, I want to have the monopolar cut of the high frequency cutting device, and I can use the functionality of a different device on the same foot switch. This has the advantage that we no longer need multiple foot switches in the operating room, and like universal control for your TV, you can also have a universal foot switch for multiple devices. And depending on the workflow step, you can also have presets which you can apply. I can show you this. Here, depending on the workflow step, you can apply multiple presets, so there's no need to adjust them all one by one. On the top bar, we have the workflow bar, and on the workflow bar is the short version of the operating procedure. So you can do a sign in, the preparation, and the surgeon can select all the necessary properties, and if needed, there can be more information for the patient. And yeah, let's just continue. Here we have a high frequency cutting device, and we used a uniform user interface by developing all of the panels here. So usually the device panel is very small. It's attached to the medical devices, and they're not always in reach of the surgeon. So sometimes the surgeon is dependent on the people setting the device properties to the value he wants. And having a sterile environment where the surgeon can control the the device properties by himself allows him to change the device properties to the exact value he wants. And he no longer needs to yell and scream people commands he wants to set. And here we can also change the value and also set it. You can't see it right now, but now the value on the device is also set to 1. If I change the value on the device, it will also change on the workstation. And if you have questions, feel free to ask during the presentation. Here we also have an OR light. I don't know if you can see it, but the light is currently turned off and on again. And here you can see we have the same widgets and we reuse them. So the user has a higher learnability value, and it's easier for him to use the device panels. And there is not a complicated user interface. They're very simplified. And if you have multiple OR lights, you will also have certain functionalities which are equal.
We really try to have a standardized and a uniform and consistent user interface, because we have so many different devices from different manufacturers that this is really important in the sense of safe and safe use for the OR staff, that we're really working on that. And this is also some topic taught we had in the last meeting, how we go on with this topic also in terms of standardization, the dev specs, the PKP. So that this is, I think this is going to be really interesting soon.
Yeah.
Sorry, Okan.
No, perfect. Yeah, the last thing I would like to show is the HMI switch. The HMI switch is not a medical device per se, but if it's used in the medical context, it becomes a medical device. And what we did, we didn't do video routing over SDP, but what we can over SDP is like controlling the inputs to the outputs. So we connected 8 signals to a video matrix, which can route any signal from any input source to any output source. And using SDC, we can route HDMI signals. So on the top left, there should be, I can just do it to a few, so you can see each better. Now the, oh wait, the speaker is also mirrored. Well, on the right side, you can now see different versions of the workstation. And using SDC, we're just routing the video signals that works perfect. And SDC is not there to replace existing standards. It's there to fill the gaps to control medical devices, which is not possible using the other standards. Well, I think that's most of it.
Maybe one addition, Okan. As you see, there is there are some solutions regarding the control from the sterile area. So if this is, for example, used with a sterile foil or with a foot switch, the universal foot switch, we give much more flexibility to the surgeon. And we also were working on different kind of approaches with gesture and voice control, and we are right now thinking, or we're already, I saw also Peter is here within us in the meeting, Peter Burri, within his master's thesis, him and Okan, they made a first approach or first functional model of using the Dragon medical software of Nuance, and which is normally for doctoral letters, but regarding the research side, I think they are really quite thinking on in the far away future, I would say, to control devices, but then their software would be medical software, which is somehow a problem, I guess. But they really think it's interesting. So we are right now working with them on these ideas, and maybe one day we also have this workstation with the speech control. We don't know. We are working on that.
How hard could that be?
Yeah.
Siri, move the light.
Oh, this would be something great. Yeah.
And I think, as you said, Okan, obviously video streaming is something that you didn't need to be integrated into SDC, but you can control that, right? The sources and those things. So it's a great example of how you can couple problems that are solved but aren't integrated, right? And so it fits that space. And I think what you just said is the whole area of haptics and height, hand-eye coordination and those kinds of things that really require tight coupling. You don't want to reinvent that wheel, but you need to be able to have that integrated in to the overall environment, and that's exactly what you're looking at here. Questions? I'm sure people for this part of it, before we move into the part B, I'm sure some of you have questions on what you're seeing here. Now.
So this is Steve Griffiths from APL. I just want to make sure I understand. So all these devices are connected using SDC?
Yes.
Yes. Like
maybe you can name all the devices we have there, Okan, on the different manufacturers.
Sure. We have a food switch we developed with Steuerte together. We have an ORT table from Mitsuhu. We have an ORT light from Trilux. Simeon, also all lights. We have an endoscopic device, multiple devices from Wolf. Insufflator, endoscope,
Light
shaver.
Yeah.
Yes, light source. From
I think it's from Esculap, I think the shaver, I think. I'm not sure.
And we have an endoscope from Shirley and a high frequency cutting device from Bova. We also have an anesthetic finger clip somewhere here, and we have our cameras attached to the all lights.
Yeah, and what you don't see today is, for example, we have a 3D X-ray system from Team, which we already had integrated, which is right now, we're working on it again. And some years ago, I think in 2017, we showed it on the trade fair. And so we are always then change of some systems within our demo OR. So but it's all different kind of devices connected with SDC.
Yeah, and the arms.
Maybe it's worth mentioning that we have different levels of integration, I would call it. So for example, some of the devices we have a Raspberry Pi or something like this, translating the proprietary protocols to SDC. And to the best of my knowledge, I think the highest integration system or integrated system is Shirley, where we have the SDC software directly within the firmware of the new FlexiVision platform. So that's I think that's the range of things we have here. It's prototypical implementations up to now, while I think most of you know that Draeger is next, or is quite near to the market with a real medical approved device.
Martin, as I know, there has been brought to public that in the end of last year that SDC-based devices are already used in the Charité in Berlin. Is right or not?
Yeah, it's so they made a press release.
Yeah.
And I think the one I read, I think it was from a clinic in Munich, and they had this triangle of patient monitoring, anesthesia machine, and the documentation system, talking SDC with a very, very small limitation, though it's a previous version of the biceps model, because we were too slow with our standardization efforts, and that's why Draeger had to move to market with a 99% version of the final biceps model. That's correct.
Yeah.
Slow is all in the eyes of the beholder. In standards land, we're doing pretty good on a standards calendar. Real world product, and technology, that's a whole different matter.
That's true. So are there more questions? If there's any question later related to our topic, we can just...
I guess the only other question, then we can transition. So you showed a number of demonstrators, and this is fantastic, because like I said at the beginning, these are real technologies that we've seen before and that we've seen out there. And you've done demonstrations for 15 years now. I mean, that's a long time. What has been the response, by the way, like in 19 when you did this demonstrator, from those who are coming by and then see it, right? But then they also get the interoperability part of the story and understand what exactly you're talking to. How has that response been at those demonstrators?
So it was in 2019, as I remember. Okan, maybe you can jump in. It was in 2019, and it was when the standards have been finalized or acknowledged in end of 18 or in the beginning of 2019. So if it have been clinical operators, clinical users, manufacturers, they all came to our workstation, and finally they asked, where can we buy it? So we have to say them, it is in a research state, but we're working on that as fast as we can. So you can really see that there's a need. And I think that everything you saw, which Okan showed, has been developed with a clinical partner. So there's nothing you can see there, which we showed, is only because we wanted to implement it because we thought from a technical point of view, this is interesting. No, this is all developed together with the clinical users. So
applied research.
This would bring some benefit, I guess. So sorry, Todd.
Applied research, in other words.
Yes.
Also on my part, during the trades, there was a lot of great feedback. People came to us and asked if we can also integrate their systems and when it's available on the market and what to do to participate. I mean, there were a lot of manufacturers, and they also asked us, is it ready to use? When can we install it into our system? And especially the integrating part is for them very interesting, like what to do to use their devices in an open integrated network.
So it was quite different to the trade fairs all the 14 years before, Todd, that before it was always like we had to push also the manufacturers and say them, do you want to join us? Do you want to work with us on that and on the products, on the standardization? And they all said, most of them, or nearly everybody said, this is incredible, this is great, but we don't have the resources to work on that right now. If the standards are ready, just tell us, and we're going to. It is true. Then implement it, and they're going to implement it. And so in 2019, it was a complete different kind of feedback. And still now we have to. I don't know the word in English that I have to. Zwicken in my skin, you know, that I really feel it, that this happened. So I was not sure that it's going to happen in 2019.
Fantastic. Thank you.
So I think we could go on with the presentation of Verena and Jonas. So the anesthesia part. And...
Okay. Yeah, sorry, Armin. And
yeah, no, I think we could go
okay.
on with your presentation, Jonas, or
Yeah.
Verena.
Yeah.
And...
then I would start our part. Later on, Verena will take over. But first I will give a short introduction again about our side. As you can see here, we are from the Department of Anesthesiology. So yeah, next to the surgery part, we are for the anesthesia part. Which, yeah, especially Verena will later go a little bit more into the details about the differences here in our project. But first, for our location, we are actually located quite near to Meditech and the university hospital, a little bit between the border to the Netherlands and the university hospital. So yeah, also well located between the research faculties and also our international partners. And usually today from our management board, Michael, who also joined us last time, would do the presentation. Unfortunately, he can't be here today, so I'm standing in for him. And yeah, for our team, we are a broad mix of physicians, but also engineers and information specialists, which I think, especially for these kind of projects, yeah, gives us a lot of benefits from the application side directly to the engineering part. Yeah, this is how we are located within the university hospital. So we are part of the university hospital, and within this, in the Department of Anesthesiology, we are a separate group which is called Acute Care Innovation Hub, and focusing within this group about yeah, these interfaces between technology and medicine. Yeah, I think here we can see the similar partners like Armin showed us before. So this broad range between different industry players, but also research institutes, startups, and so on. So our Acute Care Innovation Hub is mainly divided into three main columns, which is for once the telemedicine with eHealth and mHealth, but also one aspect is innovative sensors. So one other current research project of us is to develop contactless vital data measurement, for example, on drones, and where the project we are talking about today is located is the interoperability. yeah, which also already brings us to our ORNet part. Within our team, I brought to you here this slide with our members working or who have worked within the, let's say, ORNet universe together. So here you can also see me again and Verena, who will take over later, but also have some students helping us. Markus König, I think most of you heard of, and also Marian Olix, who is already involved, yeah, since now maybe more than 6 years. Which also brings us to our timeline and transition into our most current projects. So for more than 13 years, members of our team started from some of the most earliest steps, which then later result in the work we are doing today. Also for our most current project, Primate, what also Armin and Okan showed us today, we will go a little bit more into that later. Where we are located in Aachen, we are working in close cooperation with other startups that are also from Michael, which is Docs and Clouds and Ilara. And if you have been involved in the current SDC Pluggathons and used the ORNet VPN, this, for example, was also brought to us from Ilara.
That was just last Tuesday and Wednesday, just a couple days ago.
Exactly, yeah.
Woohoo! Good job, thank you.
And it's still running. And within this location, we also demonstrated our own showroom, which we call the Smart Health Unit, which can transition into different scenarios in the medical world. And especially for this project, right now we are using it as an anesthesia workplace / ICU demonstrator. So as you can see here, we have different ventilators, or actually this anesthesia device from Draeger, but also patient monitoring systems and syringe pumps. So here we are not only testing, but also demonstrating our most current statuses of the software. And actually this already leads me to Verena's part. So I think I would hand over now to Verena.
Verena, we're seeing your screen, but don't hear your voice. Maybe you're on mute. There we go.
Okay,
yes.
Sorry, I had some problems unmuting. Okay, so yes, let me first introduce myself. My name is Verena Vogt, and I'm an anesthesiologist at the University Hospital in Aachen. And Jonas just introduced me as part of the team of the Acute Care Innovation Hub. So for a few years now, I have been involved in research on the topic of digitization and interoperability. And now I want to explain to you our thoughts and visions about SDC with regard to anesthesiology. And since we cover an interdisciplinary research field, our team is very colorful, as Jonas just said. And we are including different professions. We have both technical and medical professionals working with us, and this allows us this kind of co-working to derive requirement analysis directly from working life from the anesthesiologists who are working in the operation room. And with their expertise and knowledge of real life situations, these medical professionals can create requirements or technical specifications or concepts and design proposals, which are then designed and implemented in software by the appropriate specialization professionals like designers, software developers, and so on. This process of co-working is not linear, but iterative and requires a constant interaction between all these disciplines, which makes this interdisciplinary co-working very fruitful. In our research group, we deal with medical device interoperability at the anesthesiological workplace, employing the SDC standard. Therefore, we have equipped our so-called smart health unit that Jonas just introduced before with anesthesiological devices, medical devices, to enable networking of these medical devices that we use in our daily work as an anesthesiologist. So shown here are the devices that are available so far in our smart health unit, and their corresponding connection to the system that we are about to establish. These devices are at different stages of SDC integration, and the core of the system displayed in the center is the development of an anesthesia workstation analogous to the surgical workstation using the SDC communication standard. And on top, we have a current research project that deals with process optimization in the operation room. So furthermore, we take into account various people or professions and different treatment sites that are involved in the perioperative processes. And I will show you too later how the visions of SDC applications for these different places are. The name X Workstation was deliberately chosen already within the ORNet project because we did not want to create independent workstations for the various disciplines, since in daily routine in the OR, the disciplines do not operate independently either. And for this reason, the same basic frame is used for the surgery and the anesthesia workstations. So you can recognize it looks very similar to what Armin and Okan showed. The main areas or disciplines can be selected in the function group menu on the left. That's what Armin explained before. And as the focus of our ongoing project is process optimization, this focus is met by a superordinate workflow bar on the top. And on the bottom, at the bottom right, the menu enables video consultations by a supervising senior physician, as well as consultation via chat. in addition to the centrally visible higher level alerts, assistance systems are positioned next to the workflow bar by means of context-related nodes or alerts. And furthermore, a generic representation of the different devices is used as far as possible. That's what Armin explained before too, to have a uniform and consistent user interface and not to be confused by the different manufacturers' displaying modes.
So one question, if I may. Some of these functions require integration with systems outside of the, as Stefan Schlichting said, the OR island of interoperability, right? Where it's kind of, yeah, this little island where things interoperate, but you need to be able to interface with others. How did you achieve that? Did you have some sort of, I know in our discussions we have an SDPi based gateway interface to EHRs or to other systems outside the context of the OR. Is any of that integrated here, or is that something in the future?
No, it's not integrated yet, but you're right. That's the thought, the vision to have the integration to information systems and other information like information you need for the workflow bar or so on. That's not integrated yet, but it's something we have in mind.
We had some prototypical implementations and connections with some hospital information systems and PACS systems, but it is, I would say we're just in the beginning, Todd. So maybe also Okan can, this is something we are right now working on. We are right now in the conceptual phase to make something of this, how I would call it, overall architecture where we can use together the different kind of systems, and we have these gateways. This is something we're right now working. I don't know if Okan maybe can explain more in detail what is the status right now.
Yes, the workstation at the very beginning was only thought as a way to control those medical devices, but you also want to see status information regarding all the contexts of the devices, and you also want to see information which go further than the medical devices, like patient data, workflow steps, workflow data, information about the length of operation, and more such infos. And to achieve that, you have to use existing information which might be in the KISS, which might also be in a IT system, which are also standardized, but they are not the same for every hospital. So we do not want to integrate a proprietary protocol, but we want to integrate existing manufacturer, we want to use existing standards to integrate the hospital information.
So the reason I bring this up is, as part of the IHE SDPi work, SDPi plus FHIR, IHE does have standards-based profiles that address all of these kinds of systems, right? And as well, and FHIR is actively used for that kind of enterprise integration, bringing in also decision support systems, for example. And so as part of SDPi, we've defined actors that are gateways for these specific areas that could be used for very straightforward standards-based integration from an OR or an ICU bed to these other systems. So that is absolutely dead center on the scope of what we're looking at with the SDPi profile. So hopefully we can link these both up.
Yeah. This sounds super. I heard Martin sometimes tells about that, and but I'm not involved in this work. So, but we heard that this could be a great combination, and also should minimize the effort. Finally, this is what I heard. So, but
absolutely, maybe not yet, but we're pulling you in as fast as we can.
Perfect. Oh, no, no, fine. Okay, sorry, Verena.
Fine. Due to the individual consideration of the different work situation of the various professions, the use of mobile devices might be helpful. For example, for sterile or hands-free work, or for people who do not have a stationary working place, but need to have the information available from different locations. And this is where mobile devices are useful. They allow, for example, the nurse anesthetist to have a focused look on the patient information or on instruction from a distant place. And here, even the use of smart glasses and augmented reality would be a possible and meaningful application, one of our visions. Here, this is something that Armin and Okan explained before. Here, I would like to make the comparison with aviation to show how that aviation shows that how safety relevant the practice of routine procedures and use of checklists are. And here is displayed the surgical safety checklist. In medicine, it is the same, especially in high acuity environments like the operation room. That checklists are used for control of safety relevant or error-prone points. And they require interdisciplinary communication about these issues. And in surgical medicine, we have this surgical safety checklist, also in the University Hospital in Aachen, but paper-based, as Armin mentioned. And the surgical safety checklist has made a significant contribution to safety, as safety critical steps are queried at distinct time points. And in our current project, or in the workstation here displayed here, or displayed by Armin and Okan, the processing of such a safety checklist is automatically integrated into the workflow. This is the operation room management. A wide range of information also needs to be available for workflow planning in operation room management, because this is where interdisciplinary processes are coordinated, and conversely, the information about these coordinative decisions to the various disciplines involved, or the different professionals involved, is necessary, and this is possible at any time with an OR management overview. And this is, again, something that's connected to IT systems. Establishing a video transmission with the simultaneous transmission of the medical devices that are connected by SDC, or transmission of the data from medical devices allows a supervising by a senior physician from a distant site, so because the senior physician can get a detailed view of the operating room, not only by video, but also by direct view of the medical devices. And this enables, on the other hand, the assistant physician to seek telemedical advice or telemedical support, as well as the supervisor to interact remotely and provide the assistance or guidance from a distance. And one last possible application concept of our project is, or vision that we have is a dashboard for the recovery room. treatment area or the post-anesthesia care unit. Here and at this place, it is clearly specified which parameters need to be monitored, and scores or other compilations of parameter limit values define when the patient is transferable to the from the recovery room to the ward. Thus, decision support for relocation or transition of the patient is appropriate or useful. Patient's transferability to the ward can, for example, be indicated by grouping these specific transfer criteria and color code these groupings, or color code the fulfillment of the relocation criteria. And since, as you can see, there are different treatment places at the PACU, at the post-anesthesia care unit, and several patients involved, an overview by the decision support application can be extremely helpful for the staff. And here in the end, you can see our email addresses if you want to contact us for questions after the meeting. But I think we're open to discuss the main questions now because we still have time to get into the discussion.
Excellent, Verena. Thank you, and Jonas. Thank you very much. And I think as we look at this, why don't you go back to the slide?
Did I lose my audio connection?
I hear you now.
Oh.
Martin?
We hear you, Martin, now.
You hear
Sorry,
us?
yeah, I think I lost my audio connection for half a minute, something like this. Sorry.
You're back.
No worries. Verena, can you go back to the slide that had the SDC connections slide? So it had the different, it had the, in the middle, it had the anesthesia workstation application, and then it showed the almost, yes, that's it. Just for this, oh, no, too far. Yes. Just for discussion here. I think the important part is, as we look at these, and those of us, a few of us that are into these kinds of anesthesia workstation applications are familiar with a lot of the features, and it's impressive what you've been able to integrate here. But we also know there's product families out there that do this, but what they don't do is have a plug-and-play interoperable foundation underneath. So everyone has to rely upon custom crafted interfaces, proprietary interfaces for integration. So that's the real amazing and excellent part that I see here, just keeping that in mind. I assume, I have a couple questions and I'll open it up. I assume, by the way, that like Armin, you can provide us with just a PDF of these slides that I can also post alongside of the this video.
Sure.
That'd be great, because I'm going to get the video up today. So we've seen the surgical workstation, and we've seen an anesthesia workstation. Have you guys looked at the integration, how these would coexist and cooperate, co-interoperate, or is that we haven't gotten there yet?
We already had a combination of these two, how Verena called it, X workstation, some years ago, and right now I think you had a redesign and rework on the anesthesia part, Jonas and Verena. So this is why we combine them now again. But some years ago we had them all on the consistent user interface all together, and although that you had different kind of workstations and different kind of computers, you are able to use the different kind of, I would say, content panels of the anesthesia devices, of the surgical devices, and then you could use them. And it doesn't matter if you're on the anesthesia side or on the surgical side. If there are some patient data or parameters, vital parameters. You could use them or visualize them on the surgical side, and even on the other side, on the anesthesia side, you would be able to put in the panel of the OR table, because we know that in the OR, the OR table is a lot of times controlled by the anesthesia staff. So this is some use cases we already implemented. And I don't know if your question was also regarding the use cases or regarding how we technically made it possible.
Yeah, so I think that excellent. And I think the point there is that when you look at the top left, for example, a patient monitor, as a provider, it can simultaneously provide to both the surgical workstation or an OR dashboard, as well as the anesthesia workstation. So you get the multiple consumers from the single provider in these demonstrators.
We use the same framework, so it also allows us to create different panels on top of the same framework.
Excellent.
But the only limitation we would technically have, I think it's also not implemented in SDC already, but if one provider has like 10 to 12 consumers attached to it, there would be a problem, because the provider should only have a limited amount of consumer connected to it. So if like 20 workstations are running in parallel, the limitation of that. Well, we talk about real life examples.
But
no,
we'll
but this is a limitation. It's true, yeah.
But we'll talk about that when I ask my Madeira question in a second here, Steve. The other thing I saw here, Verena, that I really liked was you integrate alerts. So previously we'd really looked at specifically focused on metric reporting, from providers, as well as external control. But alerting is obviously a key part here. So it's excellent that you have this centralized alerting. I assume that means you could. My question is, did you actually end up looking at a silent OR? So you would utilize alert delegation, or is that something that is again to be added into the demonstrator?
I can talk about the framework. So currently, we only route the alarms through the system and display them. But there are, of course, different types of alarms, and the alarm management is the new challenge itself.
Right.
And we from the surgical side, Todd, the framework is possible to have technical alarms and alarms, patient vital parameters, whatever. And this is the thing where we from our surgical side are not that so much into it. And also we all know these standards regarding alarms and alarm management. So I think this has to be really thought through regarding when you have a centralized possibility to show alarms. So, but this, I think Verena knows much better than us.
Yeah, the silent OR is definitely a very important point, but also a very big challenge, I guess, because it demands a lot of logics behind. One of our colleagues made several studies about noise in the ICU or these different treatment places in the post-anesthesia care unit. And these studies showed how relevant it is to deal with topics like alerting and noise. But as I said, it's a very big point to get the logics behind it and to consider all the risk management behind it, because every alarm, every alerting has its point, its reason, and to really differentiate that, I think is a big challenge.
And to be sure, there's a huge difference here between what happens at the OR table versus outside, where in the one case, you have complete focus of everybody, hopefully, right, at the table, and where silence is probably the most important part, as well as the integrated alert display. But when you're in an ICU or a post anesthesia care unit, it takes on a little bit different flavor, but you still have the same technology. So excellent. I guess the last question I have, and this is a segue to Steve. You always have good questions, Steve. But when we look at this, this specific application, and then we think about this being OR focused, and we think about the Madeira project from the APL, boy, there's a lot of synergies here. So I know you've seen that, Steve, and thought about how could you leverage this kind of systems into a Madeira kind of architecture built on top of SDC, SDPi.
Yeah, I do have a couple of questions. This is Steve Griffiths from APL. I'm interested in this view because of your connectors. Those are sleek pictures of a connector. I don't know if those are real or if you pulled that off the web somewhere. But I am interested in what your connectors, how they're built. Are they kind of standard form, or are they dedicated individual connectors? We call them adapters when we built Madeira and the reference implementation. So for us, they're hardware, software translators that speak between the Madeira network and the individual medical devices, translating and converting commands and data using SDC. So I'm interested if those images are just representative, or if they're really what your product that you're using, and if the software hardware development is unique or standardized in any way, so that you can add a different manufacturer's patient monitor or syringe pump to the system in an efficient manner, or is it a one-off every time, a unique development effort to add a new device? And why is the Draeger SDC connector? Is that the project or product that is an intermediary?
Yeah, so maybe I can answer to that. So first of all, yeah, the three black connector boxes you can see here, these images are actually representative. But actually they look quite similar, since we are also using Raspberry Pis, just in more ugly boxes. And yeah, for now they are all using very unique software solutions, so not really standardized in that way, since every connector box is basically translating the proprietary protocol of the device, like for example on the top left for the Philips patient monitor, using its own protocol. So the connector box is just translating that to the SDC protocol. But for example, on the bottom left for the B Brown syringe pumps, this protocol looks completely different. So also this connector works a little bit different in some aspects. So for now, at least these three black boxes, they are all structured very uniquely. For the Draeger box, you are right, it looks a little bit different. And it's also labeled by Draeger, since this box we also got from them, from Draeger. And as far as I know, they don't use that in clinical applications yet, but they already ship the anesthesia device with these SDC boxes. So yeah, in the end, it works similar in some way to our black boxes, but it's from the manufacturer directly. I hope that could.
Maybe also we could add, maybe Okan or Dario. I think you were the two implementing more providers than anybody else here in the surgical world for sure. And regarding the standardization of or how we can do it more in an efficient way, I would say I'm completely with Jonas when he said this is all individual solutions. But if we will get the dev specs finally for the device types, then I think we would have a real help here. But Okan and Dario, I think you can more tell about the details of provider development and connector boxes.
Yes. Can you hear me?
Yeah, sure.
Okay, yes. In each connector, there are two interfaces. The one interface pointing towards the medical device and one interface pointing toward the SDC network. And the interface pointing to the device has to be adapted to the proprietary protocol depending on the manufacturer, and does some translation to SDC. The interface toward the SDC network is using some software libraries, for example, the SDC Lib J or SDC Lib C provided by Surgitex. And there you have either a provider or a consumer side, which is filled with data from the medical device, which you get over the other interface translating the proprietary protocol. But it's this SDC interface does not only care for providing the data, but also has the protocol for communication concerning invocation state or change requests that they're processed according to the standard.
Very helpful. Just the insight as to what's inside. I guess one of the questions, and Steve, I think this is also where you're headed, is possibly having an open SDC connector piece of software or software stack or something would be very useful, because until we have a robust ecosystem of products out there that have it baked in, you're going to need some sort of connector, and having that as part of the open libraries and stuff, building on top of like the Surgitex JSON or C on a Raspberry Pi, whatever that kind of stack you want, would be extremely useful.
But honestly, I think everything we have that is possible to have it open, we still have it, because we cannot add the Draeger Medibus or the Philips whatever proprietary protocol or something like this to an open protocol stack, because this is under the rules of the manufacturers. So I think everything we can make open is still open within the Surgitex stack or within the Python stack and Java stack from Draeger. So when you have if you look into this graphic, the line from the connector boxes to the actual medical devices, this is so proprietary, and it's, in my opinion, not possible to add this to an open available stack.
Oh, but you could absolutely add that a configuration of that, or maybe, Martin, it's a paper, guidance, some short guidance document about how you would do that, what you could pull off that's open, and then what you have to add, and maybe with depending on which stack you use, the API, how that would work, providing guidance for that. It's excellent that all the pieces are already there, and maybe that's all we need, or maybe it's already there and I don't know it. The guidance for such a connector.
What do you mean with the guidance? So we have the implementation guides, or more or less the user manual for a particular stack.
What I mean is, we're going to have different concerns around the world individuals, researchers, product prototypers, and companies that are going to say, okay, let's do this. We have our device or our application here. I want to build a connector. How do I do that? A simple way, a single piece of informal guidance, coming from this community that says, here are the pieces that are in the open space that you could utilize to build such a connector for somebody that's just coming into it. That's what I mean. Does that make sense?
Makes sense to me. That's what I was kind of alluding to. If there's any standardized or provided shells or templates that were used to create the connectors.
Yeah, this is sorry, I don't get your question honestly, because all the libraries, name them SDClibC, SDClibJ, SDCRI, or SDC11073, all these software kits are these open templates, and they provide SDC. And on the other hand side, you have to implement your own proprietary protocol. And this can't be done by anyone. So for example, when we have a look into the SDClibC GitHub repository, there is a tutorial for a particular pulse oximeter. And there it is explained how you can connect this particular pulse oximeter, because there we have an open available documentation for the proprietary USB-based interface. So there's one example how to make it with this proprietary USB interface. And
okay,
when
that answered my question then, Martin. That was
okay.
my original question. So what we should do is maybe you and I can work together to make sure I have exactly the right place, and then we can craft language and direction around that, and make sure that that's clearly called out in this Gemini space that we're working on. So people that are trying to do that know exactly where to go and do that. Steve, did that answer your question?
To a certain extent. I guess I'm asking, like, each device is going to have an MDIB for the SDC communication. And I guess I assume there's going to be some kind of one-to-one correspondence between the data or control commands that are available and can be given, on the proprietary side, to the biceps model or the SDC model that the network is translating, or giving those commands over to the proprietary side. So it would seem to me that there would be some kind of a standard template, whether it's all the biceps nomenclature or the MDIB that would say, you need these 10 things to communicate with a patient monitor. And if those could be made available to innovators or developers so that they can more easily understand what is required within a connector to translate from the SDC network to the proprietary network and back.
Are you referring here to the dev specs? This is my feeling, Martin or Kaspari, or am I wrong here?
So I would think that the dev specs are one element to Steve's answer. Steve's question, because how to build up the SDC side of the connector, this is exactly answered in the future by our dev spec standards. So for example, in POC spec, we do it for the camera and light source and so on. So this would be one element of the 10 or 8 pieces of knowledge or of techniques you have to get to build up the connector. Yeah, that's right.
We've talked about this in the past. And when I say past, I mean decades past at different times, which is at some point, and I'm not sure we're there right now, Steve, but crafting up kind of a guidance list. Okay, these are the things in maybe a process that you might want to go through in being able to connect a proprietary device interface to an SDC network using, using a connector. And look at this, you have to translate this, you have to map that, you have to, but it would be a very simple guidance. And I know we've done that in the past and probably at some point should do that yet again.
Okay, very good.
All right, we're getting on. Are there other questions on either of these two presentations? Everybody's been very patient. And this has been fantastic. All right, hearing none. Any final words from Armin and Okan or Verena and Jonas?
Here in Germany is too late, Todd. We're looking for the weekend.
It's looking for you.
Yeah, it's true. Oh, we already also had a stressy week, as I told you, or the last week, so we are a little bit happy for the weekend. So,
and it's June. This is a good thing.
Yeah, it's true.
All right. Well, thank you all very much. And like I said, if you send me the PDFs, and then I'll get this recording put up, and we'll be able to have it available for those who were on holiday today. many were doing that as well. Thank you all very much. Have a great weekend.
Thank you, Todd.
Thank
If
you,
there's
everybody.
anything we can do, just tell us, and yeah, we can prepare other presentations, or as you already saw that Okan and Dario from our institute are already connected with you and coming to the meeting. So yeah, I'm really happy that we made this connection also starting from the last meeting on. So
here,
and especially the you mentioned the the hospital communication protocol you already are working on. Is there already some kind of guidance document we can see?
There's a bunch. It's a big space, and yes, we're working on. I think in the SDPi, there's 4 or 5 gateways that have been identified. For example, a fire gateway, just a standard way of going from an SDC world into a fire-based world, using the devices on fire point of care implementation guide as the basis of that. Dr. Rhodes is leading that. He's on the call. And we have in that implementation guide an SDC mapping. So an SDC to fire mapping, especially for reporting. So, that stuff exists, and we would actually profile that in that gateway actor that we've defined for SDPi. And we have similar things for V2 that would then also integrate with some of the device profiles that we have that are V2 messaging based, like device to enterprise communication for EHR, or alert communication management for remote alerting. And then we have 1 or 2 others. I forget what they are right now, but yes. And when you talk about integrating document sources, if you want to identify a document for a given patient, and there's a standard profile for doing that, or images. If you want to locate, identify, and pull in images, those profiles exist. So having gateways defined that's on one side, just as you had in your converter box, on one side it integrates with an IHE profile to access that, and then integrates that on as acts as a consumer provider on the SDC side. That stuff is all really there and ready just for us to dig into. So I think we can schedule some time to talk through that specifically, so you have a good idea of where that's headed, Okan.
This would be perfect. Looking forward working with that.
Yep, absolutely. There's lots of really great research and applied research to be done. We don't want to mess around reinventing the wheel for stuff that's just basic, plumbing. So let's get that in place so we can really focus on the stuff that's amazing and advances healthcare.
Yes.
Okay, with that, go start enjoying your weekend.
Thank you, Todd. Thank you,
Thank you,
everybody.
everyone.
folks.
Thank you.
Thank you too.
Thank you.
Thank you.
Have a nice
Bye
weekend.
bye.
Bye.
Goodbye.